Great. So you can hear me. Thank you for the invitation to be here. Thank you to the organizers and to see so many friends here. This is really a wonderful opportunity for all of us researchers and investigators to be here, so thank you for being around. I was asked today to talk about studying pain in neurofibromatosis and Schwannomatosis, and you'll note that I added the word chronic. I'm really not going to talk about acute pain. This is the pain that happens over months and years of somebody's life, and I think that's more relevant for our discussion today. Here are my disclosures of some of the things that I work on. And so I think we should start with a question of what is pain. And of course, we all have an understanding of what pain is, but there are formal definitions of what's pain. So pain is defined by the International Academy of Pain as an unpleasant sensory or emotional experience associated with or resembling that associated with actual or potential tissue damage. But I forgot to acknowledge somebody important. Where's Andres Lessing? Help me with this. There he is. So I just want to acknowledge that in an attempt to pull this talk together and make sure it's accessible. I very much appreciated Andres' help in doing so. So pain is an unpleasant sensory or emotional experience. And there's some key things to know about pain, and I think all of you will probably already understand this. It's something that each person feels differently, and it's affected by biology, by your thoughts, and social factors to various extents. Feeling pain and sensing harmful stimuli are not the same thing. Just because you're activating the sensory nervous system doesn't mean that somebody is necessarily in pain. And this really is highlighting the subjective experience we all have with pain. Throughout different life experiences, we all learn how to cope with pain and this concept of pain, and we do so in different ways. Now, one thing that's important for all of us to know, and I'm sure we agree on this, is that somebody's report of pain should be respected. And one thing I hear so much in clinic is I'll see somebody who looks great. They come in, they're well dressed, they look fine, and they're in terrible pain. And there's this difference between how they feel and how the world perceives them. And often that leads people to feel that they're not being listened to when they say they're in a lot of pain. And although pain serves an adaptive role, that is, it helps us cope with things, it also has adverse effects on function as well as our psychological and social well-being. And of course, we'll try to capture that. And then there's the description of pain, how you feel, are you in pain, is one of several behaviors that show that, but you can look at how people act and what they experience, and there are other ways of understanding and recognizing pain. And so just to continue on with some basic definitions, we think of different types of pain, and this has implications for the medicines that we sometimes choose to offer people. So when we think about pain that is due to actual or threatened damage to non-nerve cells, non-neural tissue, or from the receptors in these non-nervous nervous tissues, we call that nociceptive pain. Pain that comes from actual or threatened damage to the nervous system we call neuropathic pain. And more recently, we've been talking about a third type of pain called nociplastic pain. And I'll be honest with you, I'm just learning about this. This is not something that was even really well understood when I was going through training. And that's pain that comes from neither one of these mechanisms. And I think this really highlights, we don't just think about pain, we want to know what's causing the pain as we think about the mechanism so that we can treat it better. And I've shown you here two examples. One of a sunburn, I think of that as being nociceptive pain. That's not due to the nerves, that's inflammation and tissue damage. And then if anybody here is lucky like me and has had herpes zoster before, you know, when you have reactivation of the chickenpox virus along the nerves, that's classic neuropathic pain. And that's an example from below. So pain can take, and if you have questions, please raise your hand in the middle. That doesn't bother me at all. But pain pain comes in different forms and flavors, and if anybody here has chronic pain, I'm sure they could add to some of these descriptions. We think if you have a sensory stimulus that normally doesn't hurt, let's say putting on gloves, but that causes pain. We call that aspect of pain allodynia. Pain that is worse, a stimulus that should provoke pain but is much worse in a person, we think of that as hyperalgesia. And again, what you see is wrestling with these different experiences because they begin to express the different reasons people have pain. And one last thing to really appreciate is the role of the central nervous system, not the nerves, but also the brain and the spinal cord, where the processing of the pain experience is happening. And we know that over time, this process called central sensitization can occur. That is, painful stimuli can become perceived as more painful over time as there's adaptations in the brain and in the spinal cord. Now, some people love graphs. I like graphs. You may not. So this is for the people in the audience who likes graphs. What you can see here is if this is a stimulus intensity. So as you get to the right, something is more and more intense. So imagine somebody just like lightly pinching your finger, then harder pinching your finger, then really hard pinching your finger. And this is how you experience the pain. You can see in a person who has normal pain sensitivity, you can see when it starts low, you can see that when the stimulus is low, not much pain, but as you increase the stimulus, you get more pain intensity. And then we think about this idea of when you get an injury, it can lower your pain threshold. That's kind of the terms we use, colloquially. And you can see this idea of allodynia and hyperalgesia. Allodynia, which are sensations that normally wouldn't cause pain, can cause pain in somebody. And also the hyperalgesia, which is you feel it more significantly than you would normally. So what are the consequences of chronic pain? So we know, of course, as I alluded to in the very beginning, that this can interfere with all of our normal activities, whether it's work, whether it's family obligations, whether it's self-care. And something that I see so commonly as a clinician is when somebody has chronic pain, what I say is everybody with chronic pain has depression. I think it's virtually universal. The numbers I saw was 35%. So as a clinician, I don't believe that, but I'm just reporting what I see in the literature. And I would say the same for anxiety. I don't know anybody who has severe chronic pain who lives without anxiety. Maybe you exist, maybe you're one of the fortunate people, but I would say these are consequences that come from having chronic pain. Furthermore, my own experience, and I didn't look this up in the literature review, is that this is an example of the vicious cycle as opposed to the virtuous cycle. The vicious cycle goes like this. You have chronic pain, it makes you depressed. Being depressed makes you more sensitive to pain, and they just reinforce each other. The same is true of anxiety. So these are some of the terrible challenges people face with chronic pain. And I wanted to review with you different types of pain medicines that are out there. And what you can see here is I've tried to highlight what we think the mechanism that this type of pain medicine addresses, what type of pain it works on, some of the examples of those medicines, and whether it's disease specific. So I'll start with anti-inflammatories. These are medicines like aspirin or ibuprofen or steroids. We think they're treating inflammation, and that is what we would typically think about as being nociceptive pain. And these are not really disease specific. This is just a generic way to treat any type of inflammatory pain. The second column has to do with neuropathic pain medicines. These are that we think are working on the nerve cells to stabilize them and make them less susceptible to stimulation. Common ones are gabapentin, also known as Neurontin, pregabalin, also known as, is that Lyrica? Lyrica. And then duloxetine, which I think is Cymbalta. Those are examples. And these medicines can have non-pain mechanisms. They're used for depression, they're used for epilepsy, they're used for other things. Again, not very disease specific. These are stabilizing nerve membranes and other things. The third column is the column that's a no-no for doctors like me now. And it really highlights to me what a sad, sad place we are. So opioids, great medicines in that they bind opioid receptors, which are receptors all of us have in our body. They work on both, all types of pain really. Morphine, Dilaudid, fentanyl, not disease specific. I am old enough to have put many of my schwannomatosis and other patients on long-term medicines. We all know how that turned out. And it's very hard when there's not many options. And so what I see now is the stigma, where we can barely prescribe these medicines now for people with chronic pain. And we're really caught, both I think as patients and as clinicians, between a rock and a hard spot. On one hand, none of us want to addict anybody to a harmful substance, but when we have people whose pain is not responding to other medicines, it's really challenging. And I wish I could tell you I had the answer to that. But one thing I hate is the stigma of we do still have many patients who require opioids to get through the day. And then finally, the fourth column, which is the column that I hope to bring our expertise to, are what I call targeted pain medicines. These are pain medicines that we hope are going to act on a very narrow type of protein or other parts of a pathway that allow you to treat pain specific for that disease. And that's really what we're all shooting for, is not these non-specific drugs, but ones that are targeted to specific diseases. So here are some of the clinical manifestations, both in NF1 and schwannomatosis, that can cause pain. I won't go through them. What it highlights is a number of tumors, whether they're neurofibromas or schwannomas, or if you look here, whoops, not there. If you look here, you can see some of the orthopedic issues like duralictasia or scoliosis that can cause pain. And here's a wonderful manuscript that was published in 2019 that goes through NF1 and tries to capture some of the conditions that cause pain in NF1. And if you look closely, what you'll see is that in the review of the literature, predominantly in NF1, pain is caused by either orthopedic problems, that is bone problems, most commonly scoliosis and duralictasia, or by tumors. Those are the two most common causes. Now, somebody had come up to me before and said, I have pain all over. We'll get to that. Sometimes we have pain that we can't easily ascribe to a single thing. That's the real bugaboo and a major problem. Here are some of the, I won't go through these details. I'm sorry. So I'll just go to schwannomatosis now. So that was NF1. Now I'll talk about schwannomatosis. And predominantly here I'm talking about non-NF2 related schwannomatosis, so is not NF2 related. So in non-NF2 related schwannomatosis, up to 70% of people have chronic pain, and about a third are unable to work because of that chronic pain. So I consider non-NF2 related schwannomatosis to be, on one hand, a tumor syndrome, but on the other hand, a chronic pain syndrome. And we have looked at the relationship between tumor burden, how much tumor you have, and how much pain. There's a very weak relationship. And so as a physician entering the field, you have a very concrete understanding. You say, well, whoever has more tumors, they have more pain, and if I remove that tumor, they'll get better. And it turns out that that logic is flawed and just not true. And so we've been looking for ways to understand how can somebody with few or no tumors on MRI have terrible pain, and how can it be that I operate on a tumor, it goes away, but their pain maybe is gone for a short time but comes back. And so one of the theories, just to let you know, is that people who have schwannomatosis have microlesions. And if you look on the MRIs on the right, these are studies done in Germany where they did very ultra-high resolution MRI scans, and they can show these tiny schwannomas that we can't see on regular MRI scans. And so one of the theories is that a large number of microscopic schwannomas are disrupting the normal nerve function, and that's what causes pain in schwannomatosis. Our own data from Mass General Hospital is pointing to the key role of inflammation, and this idea that by having these genetic variants that your body is susceptible for inflammation through your nerves and the spinal cord. And it doesn't have to be one or the other, it can be both. And one of the unusual things about non-NF2 related schwannomatosis is that patients complain of nociceptive pain and neuropathic pain, even though we've been trying to understand if you have a nerve lesion, you should have nerve pain, and that might partly be explained by the basis of this inflammation. And so people always want to know, well, what's worse? Is NF1 worse or NF2? And of course, there's no answer to that. We're all individuals and they're all troubling in their own way. Here is some just information on pain intensity that's self-reported by individuals who have NF1, NF2 related schwannomatosis, and non-NF2 related schwannomatosis. The higher the pain intensity score, the worse pain reported. And it gives you some idea here of where these individuals reported. And then pain interference, as I'll talk about shortly, is how much does pain interfere with your ability to do normal things in life. And you can see all these are above 50, which is about the average. And so we know that if we look at individuals who have NF1, NF2 related schwannomatosis, or non-NF2 related schwannomatosis, their pain makes it harder for them to do normal activities than the average person. And as I alluded to, we've looked back at our series of patients who have presented to Mass General Hospital, looking at surgeries and how helpful they are. And as I mentioned, only about a third of them get durable benefit from surgery. And then we said, well, let's figure out what's the best pain medicine. Let's just start prescribing the best pain medicine. And this is just a plot to show you who's taking what. So you can see that there's a whole range what people take. And that included neuropathic pain medicines. It included the non-steroidal anti-inflammatory medicines, as well as the opioids. And you can see about half of people were on neuropathic pain medicines, about 45% were on NSAIDs, and then about a third on opioids. And unfortunately, there was no one class of medicines that seemed more effective than the other. So when somebody comes to me and says, well, what's the best medicine? Unfortunately, there's no clear answer to that. We also have some early data suggesting that if you have an LZTR1 pathogenic variant, previously what we termed a mutation, that was associated with worse self-reported pain. And so we do think there might also be some genetic influence as well, which determines somebody's pain level. So I want to transition the talk now. This is a kind of a basic about how I think about pain. Well, how do we study pain now, and how do we develop clinical trials to help people who have pain? And just to remind you about the response evaluation in neurofibromatosis and schwannomatosis international collaboration. The first thing I should say, because Steve is here, is that it's open to everybody. We have a patient representation group, and you're welcome to join that, and please look outside. But this is a international collaboration that was started in 2011, and the goal of this was to create common ideas of endpoints so that we could determine whether a treatment helps somebody or not. And we initially, we believe that by having multiple specialties and experts that we can best get agreement on these endpoints. And the goal of this was to determine and compare treatment efficacy with the understanding that this is going to change over time. That is, we're going to make our best guess now, and if we need to improve it, we will. A lot of these recommendations that we made went into the approval of selumetinib for treatment for plexiform neurofibroma. So this work is recognized by the Food and Drug Administration as well as by the European Medicines Association. And so this is how the RAINS International Collaboration is organized. We have 9 working groups. You can see that we're a multinational group, including the United States as well as many other countries. We have about 70 institutions represented, about 370 active members. And what you can see is we have working groups, and what I've highlighted in red is the patient-reported outcomes. So a patient-reported outcome is an outcome where we say, tell me about your pain, or please rate your pain. So it's something that a patient reports as opposed to something that a clinician identifies. So we can have clinician-reported outcomes or patient-reported outcomes. So we have a whole group that only tries to say, let's use the best data possible to understand what patients are reporting. So what I'm going to tell you now is what our PRO, patient-reported outcome, our PRO group recommended. So we have a number of publications now on PROs, and this is the one that really highlights the measures that we recommend for pain. So how do we study pain? We have published on 3 different pain features that we think are important. One is pain intensity. I'll tell you about that in the next slide. The second is pain interference, and the third is physical function. So pain intensity, we have chosen to use the metric called NRS11, which stands for Numeric Rating Scale 11. 11 means 0 to 10, right? 1 to 10 is 10 points. You add a 0, that's 11. This is approved for use in individuals 8 years or older. And respondents are asked to circle the number from 0, which corresponds to no pain, to 10, which is the worst pain imaginable, that best represents their pain. And I've shown you the pain measurement scale here. So this is a pain intensity scale. And again, as a clinician, you come into this and you're very concrete, and I just always assumed that this was the best and only way to represent this. But particularly not non-NF2 related schwannomatosis, but in really all forms of NF and schwannomatosis, I hear all the time that you can have a 10 out of 10 pain for 2 or 3 seconds, and that may not be the worst part. It could be the 5 out of 10 pain that always happens, or it could be the anticipation of the 10 out of 10 pain that's the most distressing. So there's a complexity to the pain experience that makes it hard to capture in a single number. So even though we're using this as our primary outcome, we also recognize the inherent limitations that we have by trying to capture somebody's pain experience with a single number. The second thing I should say is this depends on what you ask the individual on the reporting period. What's your worst pain? And then it has to be in the last day, in the last week, in the last month, however you put it. And then, of course, we have reasons to believe, we're all human. If you ask somebody about the worst pain in the last 30 days, it's not so accurate, right? A week is probably the most any of us can do, and some people would argue just in the last day. So we don't ask you every day what your worst pain is, and so we're trying to figure out what's the optimum time frame to ask people. The second thing that we made recommendations on was pain interference. And so pain interference is a scale that assesses the degree to which pain has interfered with a person's ability to complete daily activities. And we often will, again, say over the past 7 days, these are the questions, examples of questions. How much did pain interfere with your enjoyment of life? How much did pain interfere with your ability to concentrate? How much did pain interfere with your day-to-day activities? How much did pain interfere with doing your tasks away from home? And how often did pain keep you from socializing with others? So, in an unplanned change here, who here would vote for pain intensity as being the most important? And then, who here would vote for pain intensity as being the most important for us to measure on a drug? So let's see a group of hands. You can only vote once. Who would vote for pain intensity as being the most important? All right, how about pain interference? Well, we got it wrong, huh? So I see a little bit more. I would say about 3/4 was pain interference. You can imagine the FDA likes pain intensity because it's an easy 1 to 10 number. But we have thought lots about co-endpoints, and so that's very important. Well, a third one is a third domain we made recommendations on is physical function. And in this case, physical function is used to measure arm function and mobility. And so you can see here are just some of the examples of questions you might ask. Are you able to do chores such as vacuuming or yard work? Are you able to go up and down stairs at a normal pace? Are you able to go for a walk for at least 15 minutes? And are you able to run errands and shop? So again, this is getting at function now, which is what I would call a downstream experience of pain. It's not the proximal pain experience, but is the effect of pain on your life. So a third area that we've come to appreciate is so challenging is that pain is, as I mentioned, not always localized to the site of tumors. And so what we've done at Mass General, and some other people are considering doing, is to ask patients where they feel pain. Here's how we're doing it, where when we send you the scale, rate your pain on a scale of 1 to 10, and you can see this is just a cartoon showing over a period of over 100 days how that location of the pain changes. And so the goal of this is to try to understand better where that pain is over time. And again, trying to capture this complex pain experience has been challenging, but we hope we're learning more about it. So no talk on pain and studying pain would be complete without mentioning the placebo effect. All of us in this room are susceptible to the placebo effect. Some people have been putting it to very good use to help people. But in order to understand what it is, the placebo effect, as I think everyone knows, is what happens when an inactive medical treatment, sometimes called a sugar pill, but it can be other things, can make somebody feel better because how they perceive the treatment, not because the treatment itself has any effect. And as I said, all of us, 100% of us, experience the placebo effect. And it turns out that pain is one of the conditions that are most susceptible to the placebo effect. And so when we think about getting medicines approved by the FDA, it's very important to recognize that we have to show them that a new medicine is more effective than a placebo. They rarely will accept an application, and particularly for pain, that does not have a way to account for this placebo effect. And so how do you do that? We do a technique called blinding. Blinding is when the patient, usually the doctors as well, and everyone else is just not aware which treatment you're receiving. So you have two pills and they're identical, and you get half the people get one pill, half get the other. Patient doesn't know what they're getting, doctor doesn't know what they're getting. And the goal is we may see benefits in both groups because we all experience the placebo effect. But you try to show that in the active drug that the effect is larger in size than in the group that gets placebo. So now with that kind of background, I want to move on to what studies have been done. I think you'll find some of this tedious and boring because I've tried to include some of the studies, which patients were included, not because I want you to know not every trial may correspond to you. Some are for kids, some are for adults, different situations. First, I'll talk about NF1 plexiform neurofibroma trials. These are trials that were not done for pain. They were done to help people who have growing or symptomatic plexiform neurofibromas. There's two classes of medicines we've studied. One are the MEK inhibitors. Of course, everybody knows about that. And the other ones are multi-tyrosine kinase inhibitors, and the drug there is cabozantinib. And then finally, I'll end up talking about schwannomatosis. It's primarily non-NF2 related schwannomatosis, about two of the studies that we're working on, tanezumab and our Starfish platform trial. So no reminders needed here, but just as an introduction, of course, for plexiform neurofibromas, this is an individual where the MRI scan, these white areas are tumors. You can see here on the chest going down the right arm, and here's the photograph showing you a right arm that's expanded compared to the left. This is a plexiform neurofibroma. They're defined by their involvement, usually of multiple nerve roots. People are really, we believe, most likely born with these. We don't notice them until later when they've grown, but we do think that they develop very early in life. They have erratic growth patterns, periods of rapid growth, periods of less growth. They're complex in shape. They can cause all sorts of problems that are familiar to everyone here. There is the risk of transforming or becoming a cancerous tumor called the malignant peripheral nerve sheath tumor. And one of the biggest challenges is it's not easy surgically to go in and remove them completely without causing significant problems. And so that's why we do these studies. And so here are the general outlines of what it has been studied for selumetinib and other ones. We call the primary outcome, so that's what the study is designed to show. All these studies were designed to show tumor shrinkage. That is what they were done. As a secondary outcome, or additional important outcomes that they look for, include, as you can see in red, self-reported pain intensity as well as pain interference. Now it's important to understand that when we design studies and have secondary outcomes, they don't have enough patients in them typically to show conclusively that these two domains are affected. And that's because if a study, if you can show an effect on the tumor itself with 20 people and you need 100 to show a benefit on the pain, a lot of times we won't do an initial study on 100 people because of the cost, because you don't know if it's going to work. So just to understand that these trials are powered, or they're large enough to show changes in the primary outcome only. So one of the drugs that's been studied is mirdametinib, and this is a study both in adults and adolescents. This was done through the NF Clinical Trials Consortium. It was a single-arm phase 2 study, so the code word you should pick up on there whenever you see those words, there was no placebo group. So you already have to understand that we'll show you data, but this trial does not account for the placebo effect. This study enrolled individuals 16 years or older who had plexiform neurofibromas that could not be removed surgically, and they were having tumor-related symptoms. Treatment could continue up for 2 years, and their primary endpoint was to look at people who had shrinkage of this tumor by 12 months. Secondary endpoints were pain intensity and pain interference. So ultimately, they had 19 people on the trial, ages 16 to 39, and they looked at pain at baseline, at 4 months, at 8 months, and so forth. So what did they see? Before I tell you about the pain intensity, look at the right. That's called a waterfall plot. What that shows you is every bar that goes up is a tumor that grew on treatment. Every bar that goes down is a tumor that shrank on treatment. The red bars shrank by at least 20%. I'm going to call those partial responders. That is, the tumor shrank at least 20%. And you can see 8 of the 19, or about 42% of individuals, had a tumor that shrank 20%. So now when we come back to pain intensity, so that was the primary outcome. Now we're going to go to the secondary outcomes, pain intensity. So they showed that pain intensity decreased from baseline to 4 months, and they could see a similar trend, and it didn't matter whether you shrank 20% or more, that is the responders, or whether you shrank less than 20%, the non-responders. But in the group that did have the tumor shrinkage, so that's the red group, the pain intensity decreases were significantly lower at 12 months. So the other group kind of pooped out by 12 months, but the group that had the most tumor shrinkage had the most benefit at 12 months. So that was just the score 0 to 10. If you look now at pain interference, how much does pain interfere with your life? There was no difference if you looked at everybody between baseline and month 12. And then if you looked at a different month, you could see the group that had the significant reduction shows a benefit in pain interference between baseline and month 8. So you may say, why are we talking about month 8 and month 12? Well, these studies are not big enough to give us the robust effects, right, that we're looking for. These were studies that were targeted to show tumor shrinkage, and they did, but they're not created to look at pain associated with. So that's the subtlety on the NF1 data, is that we have, I think, some data, which I'll summarize in a few minutes, about pain, but it's pain that's associated with a tumor, and it gives you a general sense, but it's not conclusive. How about the SPRINT trial? The SPRINT trial for selumetinib in pediatric plexiform neurofibroma. These are the studies that led to drug approval with the FDA. Also a single-arm phase 2 study, code word no placebo group. These enrolled pediatric patients ages 2 to 18. And again, treatment could continue up to 2 years. Their primary endpoint was the same, looking for tumor shrinkage, and their secondary endpoints also looked at pain improvement in these patient-reported outcomes. So I'll just focus now on the left on pain intensity. You can see they had data on 29 of the 50 participants, and you can see that score. Let's say you started off as a 6. At 12 months, the average change was minus 2 points. So on average, every person's different. If you started off at 6, maybe you'd be at a 4, something like that. And then you can see that if you try to reduce somebody by 2 points, 5 to 3, 7 to 5, about 3/4 of individuals reported a drop that much. Gives you a sense. Now, again, we don't know what would have happened if there was a placebo group. How much would that have dropped? When it comes to pain interference, you can see that there were some changes. They asked the parents and the children, how is pain interfering with their life? And you can see that the scores dropped. That is improvements in their pain interference. That's less pain interference, reported by 38% of children and 50% of parents. It's a fascinating topic. You should ask the team about what children report and what their parents report, because they don't always align. What a shock, right? Anyway, so again, we see benefits both in pain intensity and in pain interference, with the caveat, of course, that these are non-controlled studies. Drug 3, cabozantinib. So cabozantinib is different than selumetinib. It's not a MEK inhibitor, but it does inhibit a lot of targets, and I've listed them there. So it's not a MEK inhibitor. You could call it a c-KIT inhibitor. You could call it a VEGFR2 inhibitor. It doesn't matter, but it's considered to be a different class of drug. You'll get the theme. Single-arm phase 2 study with no placebo group. This also was adolescents and adults. And then they treated people for up to 2 years, but would take you off if you didn't have benefit after a year. Again, they looked at tumor shrinkage as the primary endpoint, and the secondary endpoints were pain intensity and pain interference. So this is the same type of graph on the right. The blue are the ones that shrank more than 20%. The greens are the ones that didn't. So you can see a very similar result, and across all these drugs, very similar activity for plexiform neurofibroma. If you looked at baseline in this group, 84% of individuals who enrolled said they had pain, and you can see here their average score was a 5, which is moderate to severe. And then under pain intensity, you can see in those in the green who did not have tumor shrinkage of 20%, their average reduction was about 1, 5 to 4, 8 to 7. And those who had tumor shrinkage, that is 20% or more, the responders, you had a more robust effect, and the average reduction was 3. So again, this sense that if your tumor responds better, shrinks more, that you're more likely to have a decrease in that number. For pain interference, if you had a tumor that didn't shrink 20%, then you didn't have much benefit on pain interference, but you did if you had the tumor shrinkage. And so if the way I interpret these data, again, I told you none of these studies were generated specifically to address pain associated with plexiform neurofibroma, but when you don't have that, you look for the data. All of these studies are pointing in the same direction. And in my mind, what we're seeing is that these drugs are associated with an improvement in pain, specifically pain intensity and pain interference. And there's a suggestion that if you're somebody whose tumor shrinks more than 20%, you're likely to have more benefit. Now, what are the cautions? And I've brought these up. Beware, right? Number one is these are small numbers, 20 people here, 19 people there, 22 there, and no placebo controls. Now, that didn't stop us from getting these drugs approved, and I know that some of the people in this audience have been on MEK inhibitors and have had benefit, so I don't want to downplay the importance. I just want you to understand how we think about this, and when we go to the FDA, how do we convince them? It's a very different story in schwannomatosis. When you're designing a study to look for pain, it's very different than these associated findings we've seen in NF1. And it's time to rethink how we do schwannomatosis trials, pain trials. And I would say we've been thinking a lot over the last 10 years, how do we capture this pain phenotype, this pain experience multidimensionally to try to improve this? How do we account for the placebo effect in a schwannomatosis trial? How do we reduce the delay? How do we get drugs to people faster? How do we compare trials? If we have a trial over here and a trial over here, and somebody asks me which drug is better, how do I compare those two? And then, is there any chance we can develop biomarkers? That is a blood test, a saliva test, or something that'll tell us, is somebody likely to benefit or not? Well, of course, we're in research. We think of every challenge as an opportunity. And so here's how we've thought about going after these problems. We've tried to pull together a much more complete set of questionnaires that people fill out to tell us about their pain experience, and we can mail it to them at home and try to get that information. We've tried to think of new trial designs that can help us overcome the placebo effect and enroll people. We want those innovative trial designs to reduce regulatory burden. We want to entice drug companies into this field, and we're looking for biomarkers that can help us predict who's going to benefit. So here are the 3 drugs that are currently under study for non-NF2 related schwannomatosis. The first drug is called tanezumab, the second drug is called ciltuximab, and the third drug, I dare you to pronounce after the hyphen, I call it arenumab. You may know it as Aimovig, which is a very common migraine medicine. So I'll just go down the tanezumab route. Tanezumab targets a molecule known as nerve growth factor, NGF. The half-life, how long it lasts in your blood, half the time is 21 days. So the great thing about these medicines is you only get it once every 8 weeks as a shot. The side effects include tingling, not so bad. The challenge with tanezumab is it's not approved by the FDA. Ciltuximab, in contrast, is a drug that targets a very specific inflammation molecule called interleukin-6, or IL-6. The half-life is 20 days, so we dose it about once every 3 weeks. The side effects can include itching, rash, upper respiratory infections. The good thing about this is it's FDA approved, so if we can show that this drug helps, then we can prescribe it off-label. Arenumab, or Aimovig, is a drug that targets calcitonin gene-related peptide, or CGRP, which is an established pain molecule. The half-life is 28 days, so you get it once a month. And you can see you can have some pain at the local site, high blood pressure, constipation, but also FDA approved and endorsed by Serena Williams, so it must be good. Right? Okay, so what's the goal? The goal, I'll go over the tanezumab pain study. So the goal of this study was to compare the effect of tanezumab and placebo. So you'll immediately notice for non-NF2 related schwannomatosis, we're incorporating placebo, and I'm going to show you how in a second. And the secondary goal was to understand the safety, and you can see that we're looking at all other aspects of pain and the pain experience, including physical function, depression, anxiety. And on the right are all the health outcomes I'll show you in a slide or two, looking at what we chose for pain intensity, for pain interference, for the pain quality, for physical function, and to measure anxiety and depression. This is how we set it up. I won't go through the details except to show you that here, this is when you get screened to make sure you're healthy enough to receive it. You then get randomized. You either get, for the first 2 months in this study, tanezumab. Now, you don't know if you're getting tanezumab, and I don't know if you're getting tanezumab, or you're getting placebo, but everybody gets tanezumab in the end. So the way I think about it is you either get 2 months of tanezumab or you get 4 months of tanezumab. Everybody gets the drug. We also get to learn about the placebo effect. I'll show you a picture there in a second of what that means. And then the goal is to look at the changes there in pain and then have a safety period afterwards just to make sure that this drug is safe. Yay, we made it to the end. That study, I should say, is complete. We're in the analysis. I have 10 minutes. Is in the analysis, and we've presented some of the data, and it's very interesting and very encouraging. The next one is Starfish, which is called a platform trial. This is a trial where we can add new drugs as they come along, and we're working with the Children's Tumor Foundation, with drug companies to give us your drug. We'll study it. Put it, if it makes sense. We won't study any drug, but anyone that makes sense for schwannomatosis, give it to us, and we'll put it into the study. And the way it works is, if you have pain, you then get randomized to different drugs. We treat you for 6 months. You then get re-randomized. So if you're a person who has pain that's not currently well controlled, and you can stay on all your medicine, we don't want you to come off any medicine, but if your pain is not controlled on what you're doing, you get drug A, and then later on you get drug B. We hope we find one that works for you, and if we do, then we try to keep you on it. Now, one thing I'll just say is we're pioneering decentralized trials. What do I mean? I mean you come to Boston once, and that's it. And the rest of the time you're going to stay in your community. We're going to make sure that you're safe. It's a huge area of importance because we realize, as much as we love Boston, we love you guys coming, we know that most people can't make it to Boston. And so we're trying to minimize the burden on people trying to get involved in these trials. So this is how we analyze a placebo and also make sure that we give everybody drug. So after randomization, you either get drug or placebo, and then you get the drug. So you can see here, we can analyze at this time point who did better, the placebo group or the drug group. And then here you can see how you can also see what the effect is on extended duration or short duration. So this is the innovative trial to design that. Just very quickly here, we want to look at all of the pain experience. That includes pain intensity, pain interference, pain quality. That has to do with the neuropathic nociceptive. Here with the physical function, does depression get better? Does anxiety get better? And overall status. And we have ways of studying all those. And so finally, just to show you, as we ask people where their pain is, we also do a baseline whole body MRI scan. The red dots are where the tumors are. And what we can see is the poor correlation that there is, and we're trying to better understand that. So we're bringing these biomarkers in, including blood and other biomarkers that I won't have time to tell you about, to help us understand about pain. So here's our last slide. What are the next steps? We want to identify medications to treat pain in NF1 and schwannomatosis, but that it requires us to have a better understanding of what causes pain, and I know there's lots of questions about that. We want new drugs to study in these novel designs, and we're looking to overcome the challenges of clinical trials, such as getting enough people into the trials. The pandemic almost broke all of us in this room. We recognize the travel burden is a huge issue, and we're looking for better primary outcomes so that we can make sure that we're studying the right thing. And I'll just say that this is a work in progress as we continue to innovate in this space. And with that, just to thank a large group of people who helped out, and to recognize the Children's Tumor Foundation who has supported this work, as well as providing a travel grant for people who couldn't afford to fly to Boston, to really subsidize that to make it possible. And we could not have done it without that. And that was my backup slide, which you don't care about. So I guess I'm done. We can just turn it off.
Thank you, Dr. Plotkin. We have 5 minutes for questions, and I'm going to start with a question from the app. It's about pain tolerance. Do we, people with NF, have higher pain tolerance? And then I will just add generally, how do you think about pain tolerance as a physician?
Yeah, it's a great question. I don't know how to answer it. I think if you remember that curve I showed where it moves left to right, I think all of us have different abilities to tolerate pain. But at least in 2024, there's no objective measure that says you can tolerate pain better than me. So I think it's more about the experience. I will say that my sense is that many of my patients have very high pain thresholds, but I have no way of proving that per se. And so it's a good question, but one I'm not sure how to answer directly. Rick?
What's your experience with spinal cord stimulators?
What a good question. So spinal cord stimulators are, you have a battery pack that is implanted beneath your skin. That battery is connected to an electrode, which is a wire. That wire is very delicately threaded to the surface of the spinal cord, because we know that if you do gentle electrical stimulation, you can prevent the transmission of the pain signal up the spinal cord. So that's the theory. My own experience with that for patients who have non-NF2 related schwannomatosis has been not good, in the sense that I have not had patients rave about it, but I do occasionally have people who find benefit. So I personally don't discourage people if they don't have better options. I think the thing to remember about these spinal cord stimulators is they do make MRIs difficult. So if you're a person who has tumors in that area, you have to be careful, because you don't want to miss if a tumor is growing. You don't want to not be able to examine that part of the spinal cord. Yeah.
Dr. Plotkin, in that bar, the two bar graphs for NF1 plexiform neuromas, were those the same people going from left to right?
No, everyone was a different person. It was their best tumor response.
So some people had no shrinkage,
Yes.
but had huge pain shrinkage. They weren't
some people-
correlated.
So some people,
Wow.
in general, the correlation was the more your tumor shrank, the better the pain control. But yes, there are some people who don't have tumor shrinkage whose pain gets better.
Thank you.
I'm not controlling. I'm letting Emily run around. We have a few. Okay.
Hi, thank you for the talk. From your experience, have you seen if talk therapy or even alternative methods like acupuncture have anything to do with pain tolerance?
Pain tolerance or pain experience? I mean, do you think, does pain get better? Is that the question? Absolutely. I think pain is it's not just physical, right? There's clearly an emotional part of pain and other parts that I'm not even sure I understand. So there's no question that alternative treatments have helped. I mean, I'm a huge fan of acupuncture. I think that, for me, that's worked amazing. And so I think I always encourage people to explore anything that they think is reasonable to see if it helps. Do we understand how they work? Often not the case. There's a lot of people researching it. In the end, we don't care what makes it better. If something makes your pain better, I usually tell people to pursue it. Sometimes these things wear off, though, and that can be a challenge. They can help initially and then not later on.
We are out of time, but I want to thank everybody and thank Dr. Plotkin for being here.